Well, ladies and gentlemen, good morning. It's my very great pleasure to welcome you to this King's Health Partners annual conference. And it genuinely is both a pleasure and a privilege, because this past year has been an important and impactful year for the partnership, one which has been exquisitely dependent upon the contribution of thousands of people who have contributed successfully to delivery in our health economy, to ensure that the academic agenda led by King's College London, by the trusts that are part of this great partnership, and delivered not only in the hospitals but throughout the community, has had increasing success. And as a result, we are driving further and further forward in our mission to improve outcomes for individual patients and for the population that we have the privilege to serve. Of course, this year has also seen the departure of Richard Trembath, our former executive director, and the arrival of Graham Lord. But Graham Lord not only arrives as executive director of King's Health Partners, and of course senior vice president for the university, but also into the newly created position of Chief Academic Officer for King's Health Partners. He is ably assisted by Matthew Hotoff, who is the effective Chief Academic Officer for the Maudsley and the Institute of Psychiatry. And so, in having created these new positions, what we have done, and we are the first in our country to do so as an academic health science system, is to consolidate, to emphasize the importance of the academic clinical interface in delivery of the important agenda that has the capacity for transformation across our health economy, and to make wider contributions to our region, to our country, and globally in the kind of health sciences discoveries that we are able to establish here, and also to determine the best pathways for adoption at scale and pace into communities and health economies throughout the world. And the CAO role, an important role serving on the boards of both the Guy's and St Thomas's and King's College Hospital trusts, but also combined with the senior leadership position for health and life sciences in the university, as I say, is quite unique. And you will hear more about that today and in the weeks and months to come. But none of this would be possible without the deep commitment of those who have decided to join this important mission, a mission now that's 15 years old, and as I have said, which is exquisitely, deeply committed to patients and to the population, ensuring that all we can do, be it in excellence in clinical practice, excellence in training and the development of those who follow us, and excellence, of course, in the research agenda, that tripartite mission is applied universally across the entire health system in a way that allows everybody, patients, public, our staff throughout the organizations and throughout the community to benefit, ensuring that we can all do better and we can all deliver in the most effective fashion, enjoying the privilege of working in a remarkable area, healthcare, social care, science, life sciences, all wonderful disciplines, all with the capacity to have a true impact for society. Thank you all very, very much indeed for joining us today. It's going to be a fascinating program.
Good morning to all of you. It's a real privilege to be here at the King's Health Partners annual conference. And I've been in this job all of 3 weeks and a bit. So if I don't know the answers to some of your detailed questions, I hope you'll bear with me and give me that slight accommodation. I'd just like to start by echoing and amplifying Lord Kakkar's thanks to Richard Trembath who preceded me in this position as Executive Director of King's Health Partners. And I suspect going forward, all of the successes that will happen on my watch will be due to him, and all of the failures will be down to me. So I'm happy to take on that mantle. But no, seriously, I really want to thank Richard for everything that he's done over the last 4 or 5 years. So it's a really exciting time at King's Health Partners as we reflect on our latest successes, but also begin the development process for our 2030 strategy, which is really sort of starting today. So getting comments and input from all of you across the world and in the room is really important. You'll hear more from me in our last session today at about 3:30 on where I think KHP vision may be coalescing around and where we're prioritising. So it will be really helpful to sort of crystallise what we just discussed today in our particular areas of prioritisation. And essentially what we are doing at King's Health Partners right now, and actually politically and economically, the time is ripe for this. It's a huge opportunity for an upward inflection point, not a downward inflection point, is how we reimagine what our mission is, which is pioneering better health for all, and actually how we want you in the room and online, and actually within our entire population of South East London, to be an integral part of this development of strategy, but then critically the delivery of that strategy and the impact that that strategy will have on the lives of all of the people that we serve in South East London, but across the rest of London and actually for the rest of the UK. So for those of you who are here at last year's annual conference, we introduced King's Health Partners' 3 priority areas, and these are personalised health, population health, and digital health and data sciences. And we'll come back at the end of the day about what we mean by those areas that actually, in some senses, can be quite generic and are not differentiated from what everyone else is doing. But what are the golden threads that run through those 3 platforms, if you like, that enable delivery of impact for our patients? And in the rest of the programme today, the next few hours, you'll hear about a number of success stories in all of these 3 areas. That's how we've sort of broken down the programme. So they're illustrative about what we can deliver. And our challenge really is how we can scale these to have impact. So not just small pilots, we need to do these things at scale. And I think that's one of the opportunities that all of our partners bring together, as well as excellence in healthcare, excellence in delivery of translational research in population health, is how we do that at an efficient scale to make the impact that we want in a timely manner. So before I introduce our first guest speaker, as Joseph said, I want to inform you that we're using Slido again. So please submit your questions using the details on the slide. And actually about 10 o'clock, when we've finished our conversation, I'll invite Catherine French, who's KHP's Director of Strategy, to the stage to put those questions to us. So I'm delighted to introduce our first guest speaker to the stage. The Honourable Julia Gillard, AC, is Chair of King's College London's Global Institute for Women's Leadership, which through research, practice and advocacy is addressing women's underrepresentation in leadership. She's also the chair of the board of Welcome, which supports science to solve urgent health challenges, and also, as I'm sure you know, served as the former Prime Minister of Australia from 2010 to 2013. So it's a delight to have you here, Julia, and it's an absolute honour to have you with us. So please join me on the stage. Thank you.
Thank you, John. Thank you.
So, Julia, thank you for joining me on stage. A very, very impressive set of achievements already. And I guess I'd like to invite you to share reflections of your current role at King's College London, and then maybe follow that by your priorities as chair of the King's Global Institute for Women's Leadership. And then finally, if you wanted to, your priorities at the chair of the Welcome. So
Sure.
quite a broad introduction. So
A lot going on.
Exactly.
I'm very proud to be part of the King's College London greater family, and the work that I do is centred on the Global Institute for Women's Leadership. So I came out of my experiences in politics, having had a bird's eye view of what it can be like when a woman's leadership is subject to very gendered analysis and gendered insults. And when I sat down to write my memoirs, my story, I thought rather than write a chapter about gender that was this happened to me and then this happened to me, I'd look at the global research base about women and leadership and try and cite my experiences in a more general research base. And I found that whilst there was some marvellous research around, it wasn't as much as you would imagine, given how long we've been at the task of gender equality, which is a very long time. I personally feel like I've been at it forever, and there were many, many generations before me. And so that led to this idea about deepening the research base, and that led to the Global Institute for Women's Leadership here. And we now work across all domains, not just politics, business, health, technology, news media, the list goes on, to try and look at all of the barriers that prevent women coming through for leadership and to flesh out the evidence-based strategies that get those barriers out of the way. So very proud to work with Professor Rosie Campbell and the very smart research team there. As chair of Wellcome, I'm on a different mission. Obviously, we are a big funder of health and medical research in line with Henry Wellcome's will, as well as operating our free public access museum in Euston Road. Our big priorities under our new strategy are discovery research, so curiosity-driven science, 3 solutions areas: infectious diseases, mental health, and the intersection of climate and health. And of course, we've got the broader Wellcome family, which includes Wellcome Sanger, focusing on genomics. We've got the funding that we put into Wellcome Leap, which is a different way of funding research. We are key partners with Biobank, and around the world we have what we call our Africa and Asia programs, the APS. So we fund research centres in Malawi and Kenya and South Africa, Vietnam, India, and the list goes on. So Wellcome is truly global, but our history and our feet and our headquarters are firmly here in the United Kingdom, and we want to be a great friend and partner in this ecosystem.
Fantastic. And I think it's important that you bring this to our attention and to this room. I think one of the priorities for King's Health Partners always has been, but we need to build on this going forward, is about equality, diversity, inclusion, both in the populations we serve and in our leadership and everyone in King's Health Partners. So how do you think we're doing in that space, and what do we need to do better? What would your advice be?
Yeah, look, I think this is shared work for everyone, and it requires us to be very analytical about where barriers are for women and men in taking on all of the roles and all of the occupations that make up the vast domain of healthcare. And at the top, we still see a number of roles that are very male. We spend a lot of time at Wellcome worrying about the research pipeline and making sure that that is equitable and diverse, and that we don't see drop-offs of women, of people from minoritised backgrounds as you get to ever more senior levels. And we're making some progress in that, but it's not equal yet. But I think in healthcare too, there's this very deep conversation to be had about the highly feminised aspects of some of the professions in healthcare, nursing, caring work, which tend to be undervalued and relatively underpaid, simply because they are historically associated with being women's work. Women's work, caring work, that's really not skilled work. Women know how to do that inherently. Therefore, we don't have to pay for it very much. And if we look right across aged care, nursing, obviously this is beyond the domain of the direct health sector, but childcare, women's work remains systematically undervalued. And I had hoped, coming out of the pandemic, when everybody was on their doorstep sort of cheering for health workers and particularly cheering for nurses, that might lead to a deep debate about pay inequity, but we're not there yet. And I think there's work to be done on that.
Thank you. Well, I think one of the priority areas for King's Health Partners, and in fact we're launching it with this session, as you know, through the Policy Institute, is how we inform policy both within London and nationally and internationally in areas like this, in healthcare and life sciences, where it makes such a big difference. And I think the other aspect that I know everyone in the room knows around is also the representation of women and also ethnic minorities. It's not purely a gendered issue in clinical trials. It means a lot of our data that we base treatment recommendations on is heavily gendered as well. Particularly, for example, in sort of heart disease, where women have been excluded from many studies that we historically base treatments on. And also, I think, the other thing that I'd draw attention to for King's Health Partners that you know about, as well as gender inequality, there's some ethnic inequality and economic inequality as well. And therefore, the treatments that we have in our guidelines, we wonder why they don't work sometimes, or they're less effective than they need to be. It's how we sort of personalise health for whether it's gender, whether it's an ethnicity, whether it's poverty, and then how we address sort of intersectionality in that space as well. And it's highly complex, but I think it really needs to be an area that King's Health Partners takes a lead on, demonstrates impact. And what would you measure, I guess? How in a year's time when we come back and, if I still have a job then and we bring you back to reflect on what we've done over a year, how would we measure that success?
I think we've got to acknowledge that so many of these issues are so deep-seated that whilst you do need to have your performance indicators and be tracking your direction of travel, we really wouldn't be able to say, solve this in a year. This is a labour over many years. But one thing I think in your position, not that I'd ever have the skill base to have your position, but in your position, the very fact that King's College London, King's Health Partners, in this city, looking out to the world, the global links, but in this city itself, the diversity of this city means that it is an incredible place to be thinking about and working on these health inequalities. And hopefully, as the new government's health agenda unveils itself, and obviously that's going to be the work of more than a year too, as it unveils itself, this understanding of health inequity, how that is manifested in terms of class and race and gender, will be coming more to the fore in everybody's dialogue and discussion. So, I do hope that this is a catalysing conversation and in a year's time we can come back and say we're now doing so much more than talking about it. The following things are in operation and we're seeing some green shoots.
Yeah, fantastic. I think, as you say, coming back from spending the last 5 years in Manchester where we have a north-south divide, but we also have a urban community, coastal divide. And I think London is, 300 languages are spoken in London. Actually, we see deep inequality in wealth and outcomes. The famous, you go eight stops down the tube and your life expectancy drops 10 years. So I think this is an issue that we need to address head on, which I know we are doing because this is very much at the heart of King's Health Partners. It's good to say that, but you then need to do it and deliver and demonstrate it in everything that you do. Likewise with the links to mental and physical health that we'll be coming back to. I think you can't separate those two things at all. I think that's a unique opportunity that KHP's recognised for 15 years, and I think we need to move on that. But I think just shifting gears slightly, you mentioned the changing political landscape, and I think it'd be great to hear where you think the UK is at right now in its political sense related to health and life sciences, but more broadly. And I think the context I was just reading again this morning, that Wes Streeting went out to Australia, I think last December, and said, how do you do so well in Australia? You spend 9.6% of your GDP compared to 11% in the UK. Your outcomes are better, your cancer diagnosis rates are better. So why can't we do that in the UK? Sorry, that's a bit of a hospital pass, as we say in the trade. But
no, that's fine. Look, there are some similarities and some big differences between the Australian healthcare system and the NHS here. I would say, the meta big issues that are driving healthcare reform all around the world here, they're manifesting in Australia too. So, Wes Streeting's various mantras about the things that he wants to change, moving from treatment to prevention, moving from in-hospital care to better primary and community care. He could be saying those things in Australia and they'd resonate. So I don't want to suggest we've got it all solved. We most assuredly haven't. But it is a system that, whilst many Australians would say it is very underfunded and they want more money in healthcare, we haven't had the deep austerity-style cuts that you had here. That really is about Australia's economic circumstances. We've presented to the economic challenges of the modern age in a different position to the UK economy, and that means neither side of politics has been really on a deep austerity agenda. The issues that beset us tend to be issues about the intersection between the national level and the state level. So both levels of government are very involved in healthcare, and it can be very easy for the funding conversation to end up as an acrimonious, it's all your fault, no, it's all your fault, no, it's all your fault. And really voters are not that keen to hear that conversation endlessly. They just want someone to fix it. And we do have a more private sector section of our system. So in that sense, it's very different to here. And there are a lot of debates, there have always been a lot of debates in Australia about the role of the private sector, the role of private insurance, whether that's inherently inequitable, how it should be funded. But there is effectively a settlement now accepted by all sides of politics, which means that there are incentives in our tax system to get people to take out private health insurance. And people use their private health insurance for a variety of procedures, but there is still the social solidarity around the free public hospital system because, you know, if we were in Australia today and, you know, one of us, even the richest person in the room, went over with a heart attack, you know, that person's chances of living or dying would depend on the nearest public hospital and their treatment. And so that, unlike the US, that doesn't mean we're in a situation where upper income people are in an entirely different system from everybody else.
Yeah, I mean, it's interesting that you say about no one system's got it fixed, and that you mention America. And I was in Boston last weekend at a digital health summit talking about the funding for the US healthcare system. And as we all know, they spend almost 20% of their GDP, and they have their biggest, you know, lots of their population excluded from healthcare, and actually their population statistics are going in the wrong direction. So it's clearly not just a matter of funding.
No.
And I think if you look over the last few years, I've been working with the government in Kenya about universal healthcare access, and very, very similar issues there about how do you deliver equitable access to healthcare for a population that's of high quality, but it's also financially sustainable. And that, to me, seems to be the Nobel Prize question. How do you have all of those three? Every healthcare system has two of them and leaves one of them out. And I think really that's the question of our time. And do you think health has got too politicised, or is that just a reflection of how important the importance our population places on it?
Yeah, I think the choices you make around healthcare inherently reflect values judgments, and consequently it is always going to be at least small p political, because you know, people will come to different judgments about, you know, equity versus potentially versus efficiency, personal responsibility versus the collective responsibility of the nation state, the role of the private sector, the role of the public sector. People will have different judgments about those things on a values basis, and consequently there's always going to be some contention around them in politics. And I don't think that we should shy away from that. What we've got to avoid, though, is that debate then ending up with people lurching for you know, sort of a slipshod, non-evidence-based solutions. And I think that's, you know, if you're debating health policy and the values that should drive it, and political parties are putting forward different manifestos on that, that's all to the good. It gives the community choice. But if you've got politicians who are saying to themselves, people like, you know, they like seeing ambulances on the road, so let's just fund, you know, thousands and thousands of more ambulances because that'll look reassuring, without any sense of what that role is going to be in the system, how it's going to connect to emergency departments, what difference it's going to make to patient care, then that's obviously silly. And I know one of the things that drives people in the sector kind of crazy is that political promises often boil down to very specific kind of vertical drops without looking at the ecosystem overall and working out, if you do that, what is the ripple effect going to be. And just, I mean, you'll have an observation on this too, but I think your reference to the US does remind us that whilst we're talking about, health as health, it is a huge economic question. I mean, if you look at the, business accounts in the US, you'll see the cost of employees, the graph going, up and to the right, employees ever more costly. But when you actually dig under that, wages are just flat. The difference is health costs when employers meet health costs. It's been long remarked as a feature of the US economy that there's stickiness around labour mobility because people might hate their job, hate their employer, but if they've got good health insurance, then they can't chance their arm on moving to a wealthier part of the US with more economic opportunity because they can't risk their family's future to not have that health insurance. So they're sort of handcuffed to work they don't like, and they're probably, as a result, not very productive in because they're doing the minimum to hold the job. So, I mean, all of these things, as well as the ultimate burden on the government's accounts, have got huge economic ramifications.
Yeah, no, I think your point about economics is really important because we know that health inequalities, particularly in health outcomes, only 20 or 25% are to do with what happens in a hospital or in primary care or in community care. The rest is about good jobs and economic prosperity. And we all know, I think that the phraseology that people have used is that if we don't solve our productivity issue, whatever we mean by productivity, it can be a bit of a loaded term,
yes.
as I'm sure you appreciate. That we don't want to be a country attached to an NHS or an NHS attached to a country. I mean, because of the growth. I mean, you look at the IFS figures and, we'll be spending 350% of our GDP on health by 2050 or something. I mean, the demographic wave of multimorbidity and lack of access to primary care is with us now. We've known it was coming for 20 years, but we've not really done anything about it. And so now we find ourselves in a bit of a crisis situation. So what guidance would you give in terms of leadership? And I don't just mean, to me, everyone in this room is a leader and everyone online is a leader. We all lead at multiple levels of organisations because we have so many partners and complex systems. How do you deal with a crisis situation as a leader?
Well, no easy answer to that, obviously, but I think one of the difficulties in healthcare, and it's true in a crisis more generally, is the burden of meeting the day-to-day undermines people's ability to think about the future. And, I know people who work in the NHS, friends who work in the NHS, and it's hard. And you go in, you do your day job, you come back absolutely exhausted, and to say to that person, carve out some time, which would enable you to think about reform directions in the future is really very, very difficult.
Yes.
And often met with a high degree of cynicism because they've been through multiple reform processes where it, all devolved into not very much at the end. So I think given that the task of leaders is to look at the organisation team they're leading, the work that they're doing, and really try and plan out the strategic time for the thinking about reform, which will be meaningful and which will intersect well into the reform conversations that are happening more broadly. You can't just ask people to do that on top of their ordinary job. You've got to find a way of managing that. Otherwise, you will be perpetually in the crisis mode. Crisis also bolsters much more kind of command and control leadership models. When you're in the depths of a crisis, you do need often a central point of leadership telling everybody what to do, whereas getting buy-in for reform directions requires a much more coach, mentor, open, inclusive leadership style, and it can be quite difficult for leaders to switch between the two. And I think thinking about that and how as a personal style you're able to go back and forth between the two is very important.
And I think it's important that we reflect on that, particularly in sort of the role of King's Health Partners can play in that. with our acute trusts, our mental health trusts. It's a difficult place to be, being on, the front line. And actually, by the front line, it's not just the doctors, the nurses, it's the receptionists, it's the ambulance drivers, it's the porters, actually, that get the full force of this. And I think there's that without that nuanced leadership style, I think we're going to struggle. And hopefully that's something that we can lean on you on, about those leadership style. Because many of these are generic issues as well as health and care specific issues. So, and learning, I think, from other sectors is really important. And we've got 2 minutes left, so I just wanted to ask you, just building a bit on that crisis leadership, and we talked about austerity and the differential between Australia and the US, because I think it's a really interesting comparison. I think the comparison between European systems and American systems is less useful. I think the Australian system is, and also a similar higher education system. I think there's similarities across the piece, so it's great to have you here. And obviously, Shitty, having spent time in Melbourne, I think it's really, really useful. Is there anything you'd say about how we dealt with the most recent crisis in healthcare, which was the pandemic? And are there any lessons that you draw out of that? Because it seems to me that we're still facing sort of waves, and we probably will do for the next decade at least, of what happened during COVID, whether it's in early child education, whether it's the undergraduates we've got coming into the university, whether it's the long COVID, the mental health burden that's hugely increased post-COVID. So it's a long question for 30 seconds, so we might come back to it. But what would your reflections be?
Well, I am, I'd have to say, disappointed in many ways that the various inquiries around the world and studying of COVID, too much of it, particularly the political inquiries, I think, are about, blaming people for this or that. And there are people who did things wrong, and they should, wrong in a personal sense, obviously, Partygate and other things here. But, we're not getting to the analytical material that would help us best prepare for the next pandemic. Yep. I mean, if you, it's a political decision maker, if I was in the seat again, I can see the mental health burden that's come out of school closure. But if I was faced with another pandemic, what degree of infectiousness and death rate would persuade me that mental health burden is worth carrying, and I would still need to close schools, or that it's a bit less infectious, bit less deadly, and the mental health burden is worse than the increased infections from keeping schools open. Like, it's a judgment question, but it's informed by maths and analysis, and we're just not getting to those underlying things, the toolkit that leaders can break out. And I actually think Australia is a very good place to be studying this, because we had dramatically different regimes in different states. So with comparable populations, you can actually do a lot of contrast and compare about what worked and what didn't. So that, I think, is the thing for us to be driving as a joined-up community. Can we get to the crystallised lessons that would help decision-makers at every level come the next pandemic?
Yeah, fantastic. That's really interesting and important lesson that we'll pause on and we'll come back to, no doubt. Now, I think I've got a red light flashing down here, so I've done a terrible job here. So I'd like to invite Catherine to the stage to open up to the floor, or to rather Slido, which is not really the floor. So, Catherine, over to you.
Thank you so much. Thank you, Julia. Thank you, Graham. What a great way to start the day, and a brilliant conversation. And actually, a lot of our questions coming in are really picking up some of the themes that you've brought through today. So we have questions around leadership, hope, the role of academic health science centres in that, and really thinking about how we use those skills and experiences across HSCs to help solve some of the problems in the NHS. So I'll just pick up some of those themes coming through, particularly around this concept of the NHS, and a lot of the terminology at the moment it talks of broken terminology being used to describe our healthcare system, and we're in a very tricky spot. But what do we need to focus on? What we can do, and so I'm very thoughtful about what you're most hopeful about, Graham, in your new role, and then Julia, thinking about leadership more broadly. Graham, first of all.
No, as we said, that's is the question of our time and the question for today. And we're not going to fix it in a year. But what are our first steps? Because often, you know, where you end up is the direction of your first steps. You don't get there in the first, you know. So the directionality as well as starting is key. And I worry about terminology like the NHS is broken. When I wander into my clinic and see amazing people do amazing things, or when I take, you know, one of my family to the GP, I see extraordinary people every day. And I think it's very easy to talk it down. And what we've been talking about over the last 20 minutes, and as you all know, online and in the room, every healthcare system in the world is facing the same challenges. And again, we make different choices. And I think optimism and a vision for the future is really important, because I think that's the other piece that I'd reflect on, sort of leadership in crisis, not at the scale you've done, Julia, but if you don't have an idea of where you want to get to, you never get out of the day-to-day either. There's a bandwidth issue, but there's also where are we trying to get to. And I think if people get up in the morning and just feel hopeless, then the outcome will be almost predetermined, whatever your strategy or however strong your leadership. So I'm hopeful that the NHS will reinvent itself, as it always has done. And I think the roles of academic health science centres, such as King's Health Partners, is to give that bandwidth to provide support to people on the front line. How can, if you like, the academic power of a university work to look at analysis of healthcare data? You know, how do we bring about digital transformation? It's really difficult, but because people that are doing the day job, if you like, don't have time to do it at a sufficient scale to make a difference. As you say, it's an imposition. We've seen lots of reform before, so no investment without reform is exactly what Tony Blair said in 04 or 05. And there was investment, probably more investment than we're going to get this time, and very little reform. So I don't want to keep repeating history. And I think it's up to us to really figure out how we do that at sufficient scale to make a difference to the patients that we serve. I think that would be my reflection.
Yeah, I agree with all of that, and I think that there's a piece to add which universities often aren't that good at, but we can get better at, which is boiling the conversation down in a way that can include the community. I mean, ultimately, you know, the reform space available to the Labor government will depend on how much of the reform agenda ends up bipartisan. If I was advising the Tory party, which I'm most assuredly not, but if I was, I would say to them, you know, keep this bipartisan because it's in your interests to have Labor actually address the reforms, because people will accept the reforms, I think, more easily from a Labor government because they've got a better brand on health. You know the reforms have to be done in the national interest, and you'd be better off to cycle into government in the next wave of politics, whenever that wave comes, with many of these issues addressed, rather than make them a fierce partisan fight and hold them up. So just let Labor get on with it and basically go me too to the reform agenda. Whether they will do that, I don't know. But that's one of the things that makes space for reform. The other thing that makes space for reform is if the community gets it. And, you know, for the community to get it, we've got all of these sort of macro discussions about policy, but it's ultimately, you've got to explain it in language like you're at home in the middle of the night and your baby's unwell and you don't know what to do next. What will be different for you if all of these reforms happen? You know, at the moment, probably people would rush to an emergency department, you know, sit there, unless the baby was diagnosed as critically ill, sit there for multiple hours to then get some probably quite, you know, usual parenting advice and then sent back home. You know, what would be different for you? And for the parents and community members to understand that their intersections with health would be much more efficient, much happier, they'd feel much better supported. We've got to paint that picture.
Yeah, absolutely, absolutely. Really important point. And I think linked to that, we have questions coming in through, you know, you talk about being at home with your baby at night, and there's a lot relating to, I think, inequalities in women's health that's coming through the narrative at the moment. And we have a question from Laurie Lee thanking you for your analysis earlier and then referring to the Care Quality Commission report last week that identified maternal health care as really needing improvements across the NHS, and a real example perhaps of gender and race inequality in this area. So he would welcome any thoughts you had on changing that and how we could do that quickly. Perhaps I'll come to you, Julia.
I'm not sufficiently expert in the UK system to offer very specific advice on that. You'll do much better than me, but we certainly know in Australia that we've had to think about and work with local leaders on quite different models of care for the most disadvantaged communities. And in Australia, the most disadvantaged communities tend to be Aboriginal and Torres Strait Islander communities, where low birth weight babies, more pregnancy complications, maternal mortality is more of an issue than it is in the Australian population generally. And so I think, whilst there might need to be systemic improvements for everyone, there is probably a lot of thinking to do around one size doesn't fit all when it comes to pregnancy and birthing support.
No, I mean, I think this is one of the most, if you like, disappointing reports, because we've not moved on since the Ockenden report earlier, which identified these issues and actually gave, in the sort of the Darcy terms, gave a prescription for what we should do, and it clearly hasn't worked for a variety of reasons. I think your comments, Julia, about the community, helping people understand why we're doing it, I think is a broadening out of what we mean by the P of King's Health Partners. I think we're not just the organisations, actually we are the community. And I think that's what we need to be, and I know we already are moving towards that. That is what the King's Health Partners are. And I think understanding that one size doesn't fit all, we learned very clearly from COVID vaccination, for example. Again, we've got to learn lessons about what we do better for the future, about where people would go to get vaccinated, because we know that the people that initially were more resistant to vaccination or harder to reach, and I get told off for saying that easier to ignore rather than harder to reach, I think is the phraseology that I'd use. You have to have different modes of delivery. So in Manchester we went out and had a van and went out, delivered vaccinations in mosques after discussion with imams, and I think that's how we need to, and that's, if you like, the soundbite of moving care from hospitals to a community. It's really what it means, is working with the community. So it's not that these are policymakers and senior leaders doing it to the community. It's co-producing with the community what it is that they need, so that in the middle of the night, what do you do? Who do you talk to? I think building a sense of community, which is very, very strong in South East London, and I think a specific example was on Tuesday we launched our Better Health and Care Futures in the community centre around the corner in Southwark, and actually inviting people in to listen to what it is that they need. I think it's quite important. It's easy to get separated from that when it gets down to budgets and politics and models and transformation, which are all important. So it's how we remain connected to our community in a way that matters to them and that we understand it, and whether that's, as you say, Torres Strait or Aboriginal population, Black, Asian populations within London is a really important reflection. And I think because we also see different aspects of healthcare disproportionately affecting different populations. So you mentioned one around maternal health, but also in terms of mental health, and you see this stratification across all of our healthcare systems, and you see this, essentially sort of structural racism in this, and I think we need to take that head on and not shy away from it. It leads to uncomfortable conversations, but actually unless we have those conversations, we will never address them properly.
Great, thank you. And then I think perhaps to come back to the theme of leadership, Julia, as you mentioned earlier, a question really thanking you for your really helpful description on how you interweave those different leadership styles, and that being very apt for the NHS's current needs, and in particular a focus on prevention as well as treatment might show that shift. So what would be your advice to NHS and political leaders about how to make that shift to a more blended leadership styles? Yeah,
I think people people are going to need to see in more granular detail the sort of big picture government reform directions. So there's all of that to come, and obviously people in this room, online and beyond, are going to be active partners in that discussion. And then there's the, coherence, hopefully, that can be built around those reform directions. And then it gets to this question of personal leadership style and how you take people through a journey of change. And in today's world, you can't, it's hard to sheepdog people into it. I think the days of sort of hectoring people into change, if that was ever a strategy that worked, they're well and truly gone. Hire people in the NHS with great skills. They've got other options as to where they work. Many of them have exercised those other options and exited the system. So you won't be able to hector them into it. You've got to, be painting the picture about why change will ultimately be better for them as well as better for everyone who uses and relies on the NHS, and hopefully better for their working lives in the sense of, less stressful, less frustrating. And so it's that, switching to that inclusion, listening to people, over-explaining, never thinking that people have caught on to it first time round, because they won't. On the change things that I've seen in operation, where they go wrong is that people assume, because change has been explained once, that everybody's pointing in the same direction. Generally not right. People need it explained and explained and explained. And people don't listen to the stresses and strains that get fed up from people, so they're not modifying the change journey, understanding the human dynamics to it. So both of those things take a lot of kind of strategic patience and emotional labour, and as a leader you've got to be ready for that.
Wonderful. Thank you. What a great message to finish us on. Thank you so much. A lot of the themes and the questions we'll pick up later and throughout the day, and particularly in Graham's talk at the end of the day. But I'd be really grateful if people could join me in thanking Julia and Graham for setting us up today. So it's great. Thank you.
And you.
And now I just need to hand over to the next session to one of our brilliant leaders within King's Health Partners, Gráinne McAlonan, who is Director of the National Institute for Health and Care Research Biomedical Research Centre, which is based at South London and the Maudsley, and she'll be chairing the session on personalised health. Thank you very much.
Thank you. I think that's our cue to start. Thank you very much to the previous speakers. And this is the section on personalised health. And when I was thinking about how I go about a personalised health agenda, I was thinking, first of all, it's about recognising that people are whole persons, and they're complicated, but still individual. And what we need to do is really discover and learn how to better target both preventions and interventions to support better health. And really to action those discoveries is the work of translation, and by that I mean translating into the clinic and into our communities. But most of all, that process needs to be carried out together with lived experience experts and also our communities. And that's really the process that's enabled by the new Centre for Translational Medicine set up at King's Health Partners. And today, reflecting back some of that hopeful message, which I hope comes across, we have our inaugural director of the Centre for Translational Medicine, Phil Newsome, who will explain what we're trying to do. And then we have some of just a little snapshot of some of the awardees of the funding that we've made available to really support translational medicine. And honestly, I was sitting on some of the shortlisting and interview panels for these awards, and the talent was exceptional. So I hope that this just gives you a tiny flavour of the talented individuals we have at KHP, and you'll also see something of the range of that whole person piece that's carried out. But over to Phil.
Brilliant. Thank you very much, Gráinne, and it's a great pleasure to be here this morning. So I've been here I'm entering my sort of third month, so Graham's had 3 weeks, so I can take a bit more flack. But it's a really exciting time to be here. I've come from Birmingham, where I was director of the Birmingham Biomedical Research Centre. So what I'd like to really capture today, what is the CTM? Who's in it? What does it mean? And ultimately, what does it mean for people on the ground? So I think, at a difficult time, I think what's really exciting about the Centre for Translational Medicine is really sort of testament to the support of the various stakeholders who at a very difficult time have contributed over £30 million to trying to really drive translational research across the partnership. And really, a really exciting element is Guy's and St Thomas's Charitable Foundation putting in over £8 million. It's a really exciting venture, and again, testament to the commitment to delivering this. So, when you think about translational medicine, it's important to think about the team. And this is the team here. So Emily, if you could please wave your hand. So Emily is the program manager, but you can see here also have Sarah Crabtree, who's going to be driving our approach to patient and public involvement and engagement, also Joe Murphy, and recently Rachel. But of course, they're supported by very many colleagues across the partnership, at GSDT, at King's College Hospital, but also KCL. So I think one of the questions about, what is translational research? And it means different things to different people. To me, it's relatively simple. It's a process rather than a specific entity. And it's about how we try and flow information. And actually, that can be in both directions. It can be from discovery science down to population health, or indeed the other way around. And I think that, you see here the mission statement. For me, the Centre for Translational Medicine will focus at the sort of translational T1 and T2, which is translation into humans and translation into clinical systems. But of course, it's important that it communicates efficiently, both upstream with discovery science and also with colleagues in population health. And one of the challenges is how we break that sort of 17-year from discovery to implementation. And I think in terms of the mission statement, again, this has been outlined already by Graham. I think, there's a sort of duality here. At one level, we absolutely need to deliver better outcomes, address health inequalities in our local population. But also, I think one of the advantages of London, and it was the same in Birmingham, but at a different scale, is that our population is incredibly diverse across pretty much every demographic. And it means that the work that we generate, if we do it correctly, not only has a value locally, but also becomes globally relevant. And it means that the work that we do can be taken up, can be commercialized wherever you are in the world. I think in terms of the three key objectives that I see in terms of the CTM, apologies for the acronyms, is really to try and accelerate translation. So that's identifying the barriers, identifying the facilitators, and really moving on those. The second thing, and as has been touched on in a number of reports, is increasing the number of individuals that are involved in translational research. Now, just to be clear, that doesn't just mean doctors. It means nurses, it means midwives, it means allied health professionals. It means anybody who's interested in moving that knowledge up or downstream. And then finally, it's about creating a sustainable environment. Clearly, there are some major funders in this space, and I'll touch on that in due course. But what I would like to see is creating a much more diverse series of large infrastructure funders. So it's thinking about biomedical research centres, but it's also thinking about large industry partnerships. It's about thinking about other infrastructure from other funders, but also working and developing broader links with philanthropic funders. And again, the US is a sort of paradigm that we can try and learn from, recognizing there are some cultural differences. So in terms of the principles of the CTM, I see these as much as values, and I think they'll be embedded within the work or the way we work at King's Health Partners. So it's thinking about partnership working, and there's multiple different levels to that. There's working closely the advantage of our population is not that we have a population, it's that we will work with our population to understand the challenges and how they want us to interact with them. It's also being the partner of choice for other academics across the UK, internationally, but also industry. And we've touched on equity, equality, diversity, and inclusion, and I see there's multiple dimensions to that. One is around the workforce. And I guess the question would be, does our research workforce look like our NHS workforce, and does it look like the local population? And I think there's been touched on in some of the questions on Slido. I think there's work to do there. But also thinking about how public and patients are represented in the studies that we do. And again, there's work we can do, but it starts off with the first question, which is your study representative of the people that are affected by this condition? And then finally, I think it's starting with end in mind, and we have a unique opportunity here to make sure that we can flex the way we deliver care. I was speaking to a colleague a few weeks ago about some really interesting work that's been funded here, looking at a lifestyle intervention with pregnant mothers, and then looking at the outcome in children. And it was really impressive, and yet it hadn't necessarily percolated through to how we change clinical care. So this is within our power. We should be driving the agenda nationally rather than waiting for directions on how to do that. So this diagram here, I'd like to thank Tom Fowkes for translating my hand-drawn scribble into something more professionally looking. So I think what it tries to capture is the ethos of the CTM is creating an ecosystem around how we approach translational research that is efficient and also the envy of others. Now, there are sort of two broad dimensions. There are things which the CTM will drive directly, and that will be around priorities, it will be around capabilities, it will be around how we use pump priming to create and support the next generation of researchers, and then it will work indirectly, adding value across many of the key elements which are important in delivering translational research. So we can maybe touch on some of this in the discussion session, but for example, for priorities, I think now is a unique opportunity to lift our heads up and ask the question, what should be the disciplinary and interdisciplinary priorities? And for me, that's a triangulation exercise between local priorities, national priorities, where our research strengths sit, and also what we think will be important, not just now, but in 5 to 10 years. So again, we're convening a range of different stakeholders to drive that, and that should come through in the next few weeks and months. And then building on that is all thinking about capabilities, whether that's bioresources, whether it's clinical research facilities, whether it's how we access and analyze healthcare data, manufacturing facilities. Again, asking the question, what do we need not now, but in 5 to 10 years? If I then skip on to the bits about how we work with others, again, this is complex, but it's really important that we understand how do we integrate the various different infrastructures to add real value. Often I think I see this as happening towards the end of a competition, for example, with NIHR, but I think we need to really try and deliver those efficiencies now rather than later. Working again with the very many entities such as Cato and such as the delivery of training, it's again, how can we add value in terms of we will support individuals, but then it's about the technical training, it's the leadership training, and again, that was touched on today in some of the challenges. And then thinking about innovation at pace. Now, some of that is at one level very exciting as we think of different ways of delivering trials, which might include data-driven trials where individuals are recruited and randomized in primary care to an experimental medicine interaction. But also there's the more, not exciting, but it's really important, how do we get the processes more efficient? How do we make setup much quicker? If you speak to industry, what's their biggest bugbear? It's time. It takes too long to get contracts set up, too long to get things set up. Now, there's a reason why this is difficult. So it's not as if people are trying to slow things down at all, but if we can get that right, if we can get studies set up quickly, interactions quickly, we'll reap all the rewards for that. And then finally, in terms of commercialization, to me, there are several dimensions to this. The first is that it creates a different ethos, but also I think it's about how we demonstrate economic value. Whether we license it out to companies or whether we spin out, it's a critical element. Remember, the investment in research, a large element of that was around economic growth, which allows us to do everything else. So, much of this work started before I came, but it's been great to see just the level of awards in the first year. Again, a range of different schemes, at different stages in people's careers. And again, the nice thing has been is that there's been a range of awards across a huge number of disciplines and also number of different partners. And I think if you see here, you get a flavour really for the kind of the different awards and the different individuals, and you'll hear some of that in a few minutes. I think the nice thing is that if you look at the composition of this, you'll see that I think we are really addressing the demographic of our awardees, and you can see a nice range of the clinical disciplines that are supported. This is just a snapshot of some of the individuals, and you'll hear that come alive in the next session. But then finally, just to close, the next round of calls is due to open soon. It's not just more of the same. We're also going to have some dedicated funding for nurses, midwives, allied health professionals, recognizing they're an underrepresented group in our research. But also, we're reinventing what was the old CARP scheme. In other words, a scheme whereby we can buy out research time for clinical colleagues. And again, that represents all healthcare professionals. So please look out for the calls. Please apply, and look forward to helping us drive this forward. Thank you for your attention.
Thanks so much, Phil. And now we have the first of our awardees, and I'd like to welcome Dr. Yevedzo Ntuli, who is a predoctoral associate supported by the CTM. Over to you.
Thanks so much. So hi everyone, my name is Yevedzo Ntuli, and I'm a gastroenterology registrar, and I'm going to tell you a bit about the project that we've received funding for. My two supervisors are Professor Debbie Shawcross and Dr. Lindsay Edwards. So just a bit of background to set the scene. We know that chronic liver disease represents a significant unmet health need. And if you look at the mortality rates compared to lots of the other major diseases presented on this slide, you can see that they are continuing to escalate over time. And this is because we just don't have any curative treatments for cirrhosis, which is the end-stage complication of chronic liver disease. We have transplantation, but that's obviously a very finite and scarce resource, not available to everybody. And just to kind of set a bit more of the scene, we know that patients with cirrhosis exhibit gut dysbiosis. So this means that they have an overgrowth of pathogenic strains of bacteria within their gut, and they have reduced microbial diversity. So this damages the gut wall or the epithelial barrier and allows bacterial products to translocate into the systemic circulation and can cause inflammation. And we believe that this mechanism underpins reasons for decompensation and infection in patients admitted to hospital and is a big reason for the mortality rates in liver cirrhosis. An analogy that I can't take credit for, this is Professor Shawcross's, but the idea of thinking about a healthy gut microbiome as this abundant bucket of chocolates, and anyone who works in the NHS will recognize the picture on the left of all of the flavors that nobody wants. So if you think about a dysbiotic gut a bit like that, the aim of this work is to identify what those pathogenic strains of bacteria are. And what we want to do is develop a bacteriophage or work towards developing a bacteriophage to target those pathogenic strains. And we want to look at stool samples from patients with cirrhosis. So what is a bacteriophage? Well, it's a virus, or many viruses. We all have bacteriophages within our gut ecosystem. We have millions of them. And they form part of a bacteria's natural armory for colonization of their environment. And what's special about them is that they can specifically infect and destroy bacterial cells. So they represent a really targeted approach to bacterial death. And they don't infect human cells or sort of commensals around them. So they make a really great alternative to antibiotics. And in the age of antimicrobial resistance, this is something that we should really be moving towards. So that's phages. Where are we going to get our stool samples from? So the PROPHET trial was a randomized control trial done at King's looking at fecal microbiota transplantation in patients with cirrhosis, FMT. And we know that FMT does change your gut microbiome, and this image, which was created by Dr. Edwards, shows a representation of a gut microbiome in a healthy control on the left, where you see there's lots of diversity. And if you look at the cirrhotic patient on the right, you start to see clustering of pathogenic strains. And once a patient is given FMT, you can see that you have a return to microbial diversity and engraftment of the healthy donor. So changes happen. And this approach is a sort of whole gut ecosystem approach to addressing the dysbiosis problem. And what we're proposing with this research is to do a more targeted version of that once we know which bacteria are causing problems. So the plan for the project is to interrogate the deep sequencing data that we've done on the stool samples from the PROPHET trial to identify what the pathogenic strains are and correlate them with some of the negative mechanistic outcomes. We can also look at which phages are upregulated after FMT, which will give us some clues of what to target. We then want to approach a commercial source of GMP-grade phage provider to try and understand what we need to set up a phase 1 clinical trial to use phages in chronic liver disease. We'll be working with patients and the public throughout this process with our connections with the British Liver Trust. And ultimately, what we want to do is to either set up a first-in-man clinical trial using phages in chronic liver disease, or to develop and validate our own phage. These are my two supervisors, Professor Shawcross and Dr. Lindsay Edwards, and I'm happy to take any questions. Thank you very much.
Thank you. Thanks, Yevedzo. And I should have said at the beginning, we'll take questions at the end. So please, if you could use your Slido to insert those questions, I'm going to monitor them as we go along. And just now, we're going to pass over to Ryan McNally, who is a pharmacist and one of our postdoctoral associate award holders.
Thank you very much, Gráinne. And first of all, thank you to KHP for inviting me along today. I'm sure all of us will agree it's really great to get this kind of exposure quite early on in our career. So I'm Ryan McNally. I'm in quite a niche position in that I'm a pharmacist and now a postdoctoral researcher. And thanks to the funding from the Centre for Translational Medicine, I'm now getting to work on this project for the next 2 years, which is called Hypertension, the Silent Killer. So a bit of background, I'm sure most people in the room are probably aware of this, but hypertension is the single most important risk factor for heart and circulatory disease. And it is recognised by NHS England to be one of the biggest areas where lives could be saved over the next 10 years. And despite the availability of pharmacological treatment, which is sort of readily available and highly cost-effective, unfortunately, about 1/3 of patients do not achieve optimal blood pressure control. And this increases both their cardiovascular risk, and it costs the NHS an estimated £2.1 billion per year. There's been a lot of research done looking at ethnicity and hypertension and kind of around reducing health inequalities. And it's something I'm really interested in because luckily where the clinic I recruit from in South East London is located, we're really lucky to have a really high proportion of BM subjects to include in our research. But if you look at the study by Lane et al., across the life course, African origin patients are disproportionately affected by hypertension, and they're always more hypertensive at screening. Then whenever we look at blood pressure control, again, when we look at this data, we see that black patients always get worse blood pressure control. And then obviously when I say hypertension leads to cardiovascular disease, across the life course as well, we see a higher incidence of stroke in black patients compared to white. So my fellowship, as I said, for the next 2 years is a personalised medicine approach to treating hypertension, or the silent killer. Personalised medicine for hypertension is using drugs that are most effective for the individual patient. So whenever we look at blood pressure treatment, it's usually a stepwise approach with varied drug efficacy. But personalised medicine could lead to better blood pressure control and reduced side effects. And ultimately what we see is that the patient is more engaged with their treatment. So the overarching question of this fellowship is, are there simple biomarkers that could be used to develop true personalisation of antihypertensive therapy? And really my fellowship has 3 objectives. Objective 1 is to perform a systematic review and meta-analysis of renin-guided therapy. For those of you that don't know, low renin hypertension is particularly prevalent in Black African hypertensive patients. And it has been proposed over sort of the last 5 decades that plasma renin-guided therapy could potentially lead to better blood pressure control, often with fewer antihypertensive drugs. However, this has never been systematically tested and meta-analysed to really give us an overview of whether or not this is worth our time. And then secondly is to look at the predictive value of biomarkers in a recently completed antihypertensive drug trial. Now, the results of this trial overall, the blood pressure was the primary objective, will be available within the next few months. But this was a trial called Aim High, which I worked on as a pharmacist and a PhD student over the last couple of years. If we look first of all at the monotherapy arm, what we see is patients that were suitable for washout or were untreated at baseline were cycled around in random order, amlodipine, lisinopril, and chlortalidone, a diuretic, for 8 weeks each. What we have is a full biochemical profile at baseline. We have echocardiograms, blood pressure, and then we have it after 8 weeks of each treatment as well. And it's to really look at kind of, were there any, particularly renin, was there any biomarkers within that trial that we could maybe be used to predict response? And what's really good about this trial as well is we had a very high representation of Black African patients, which are historically underrepresented in clinical trials on antihypertensives. And thirdly, it is to develop a national registry of biomarkers for testing prediction of blood pressure drug response. As I said before, hypertension is the leading cause of cardiovascular disease worldwide. And aside from primary hypertension, we also have secondary causes and also other rare forms which contribute to this burden of disease. However, so far, no information is captured on a national level. And luckily, I'm on the executive committee of the British and Irish Hypertension Society and the Collaborative Research Committee. And I have the support from sort of the key opinion leaders and stakeholders around the UK who sit in these hypertension specialist centres to really get this registry set up. And so far, there is no registry, and there is registries for renal diseases. We see it with radar, and also cardiomyopathy. So the plan for the next 2 years is really to get the infrastructure of this up and running to then apply for a more substantial fellowship with the NIHR. So just to conclude, really I hope that objective 1, 2, and 3 together will at least give us some insight over the next 2 years as to whether or not we could personalise treatment for hypertension. Thank you very much.
Many thanks, Ryan, and for keeping beautifully to time. Now we can introduce Matthew Hollocks, who's a senior clinical lecturer, and he will be the last speaker of this session, and we'll have questions and answers after Matthew.
Great. Hi, yes, my name's Matt Hollocks. I'm a clinical psychologist and a senior clinical lecturer at the Institute of Psychiatry in the Child Psychiatry Department. And there we go. And today I'll be talking about a KHP-funded pilot study which hopes to open up a new avenue of research which will very much focus on trying to better understand the links between aversive sensory experiences and anxiety in autistic youth, and in parallel to that, allow us to develop a novel psychological intervention approach to work with this group with very few intervention options but very high clinical need in terms of their mental health care. So in terms of sensory differences in autism, so most autistic people experience sensory differences. These vary in intensity but manifest across all sensory domains, and they tend to be commonly described in terms of hyper or hyper-responsivity, for example, to sounds, touch, smell. And we know that these aversive sensory experiences have a negative impact across a range of activities, particularly in terms of engaging with education successfully. So you can imagine, for example, a very noisy classroom setting being difficult, and overall this having a negative impact on well-being and mental health. So alongside that, we also know that around 40% of autistic people have at least one co-occurring anxiety disorder, with generalized anxiety or social phobia being the most commonly reported. And in addition to that, around 80 to 90% of people will have elevated symptoms of anxiety, even if they don't meet the criteria for a DSM-defined anxiety disorder. So it's a major clinical issue, and a lot of people seen by CAM services have autism and anxiety, and we have very few treatment options. What we also know from cross-sectional research and experimental research is that sensory hyperresponsivity is highly correlated with anxiety. But what's less well understood are the kind of intermediate psychological processes that occur between having an aversive sensory experience and developing a full-blown anxiety disorder. And key to that, within that question, is the directionality of the two. So is it a unidirectional process whereby you have aversive sensory experiences, therefore you develop anxiety, or is there a bidirectional association between the two, whereby having anxiety makes you more sensitive to sensory experiences and kind of creating a feedback loop? We don't really know that, and there are two key ways in which we could explore that. One would be a longitudinal type design, which is very expensive and impractical, and the other is the approach that we're going to take in this study, which is using an experimental medicine style paradigm where we try to modulate one of those two factors to see the knock-on effect of the other, and we'll be trying to modulate anxiety whilst also developing a psychological intervention that targets anxiety associated with aversive sensory experience, working with autistic individuals, allowing us to both develop the intervention and test this experimental hypothesis. So this is really kind of best summarized, I think, in this figure, which kind of demonstrates the different levels of data that we're planning to collect. So in that picture on the right-hand side, you have a potentially aversive sensory experience, maybe very noisy, people brushing up against you, being in close proximity. That might be very difficult for an autistic individual or anyone perhaps. You can replicate that by developing stimuli, so auditory stimuli, tactile stimuli that you can use experimentally, and you can then measure the biological response using EEG to that stimuli, and you can also measure the perceptual response, so people's differing thresholds in detecting and discriminating those sensory stimuli. And we already know that autistic people have differences in processing at those levels, though that set of experimental batteries is very well established. And we also already know that that's correlated with higher levels of anxiety and the presence of anxiety disorder via its reactivity that we can measure using physiological recording. Now, what we're doing here is to try to modulate that response, is we're developing, using a co-design process with autistic individuals, a 8-session CBT group intervention that will equip young people with the resources to challenge their beliefs, thoughts and interpretations about aversive sensory experiences, as well as manage the associated arousal or emotional response to those sensory experiences, so that when they go back into them, they're better equipped. But also by doing so, we're testing whether or not that has an effect at a biological level. So it does it kind of almost down-regulate sensory thresholds, and so we can test that bidirectional hypothesis whilst also developing that intervention. So really the key goals of this project are to establish a proof of concept for that experimental model that we can then upscale in future studies, show that our intervention can be used to modulate an individual's response at a biological and perceptual level, and also identify which of the measures we have are most sensitive to that. And I guess potentially most importantly, gather acceptability data and work with autistic individuals to get feedback on that intervention so we can further refine that to use clinically also. And I think the other key thing that this award has allowed us to do is bring together, and I think this is important for translational mental health research, bring together clinical experts in EEG, sensory neuroscience, and autism interventions all together into one team so that we can move this project forwards. Thank you.
Thanks, Matthew. So we've got some questions coming in, and I'll do my best to pull out the main themes. Phil, this one to you. Have you managed to devise a successful strategy on how to work with industry as another means to attract funding and remain financially sustainable? If so, are you able to share this?
3 months, yeah. Okay. So I think there are several elements to that. I think, what is it that attracts industry to work in an area? I mean, partly it's through they recognize the individuals that are working in that area. So there's a sort of a personal link there. And I guess as an institution, it's how you build on that and broaden it for a given company. But, it's recognizing that some interactions will be focused, some will be broader. And it's about having an enabling system, so supporting colleagues to how to have those interactions. It's around, as I alluded to, the sort of ease of, or the removal of friction within the system. So speed is a key one. And of course, there are sort of master agreements you can generate such that it's easy to evolve those. I think the complexity comes in terms of how do we go from having a number of discrete industry interactions to having the overarching ones. If you look at Oxford and their £100 million investment from Novo Nordisk, it's how do we make that step change? And I think then it's around how we understand better what it is that specific company wants in terms of how we aggregate different areas and sort of broaden that relationship. So I think it's clear lots of excellent work going on, but it's, I think for me, one of the key priorities in the next phase.
Thank you. And if I go to Yevedzo, I think there's a huge amount of interest in the microbiome. So now you're our resident expert. Can you see a potential to extend beyond the kind of work you've proposed for chronic liver disease?
I mean, absolutely, and I think a lot of that is going on. I know that one of the biggest utilizations of bacteriophages is in antimicrobial resistance, and lots of countries are able to kind of generate phages because they have the right legislation to do so, to treat highly resistant organisms. And I think in the UK, we just don't have that legislation available. And so when we are applying for things like bone and joint infections, or I think those are the most common ones, or skin infections, it has to be done on compassionate grounds, and it's very difficult to get hold of. But I think that's one of the biggest areas where we have a huge unmet need as well, is antimicrobial resistance.
Absolutely. And I hadn't realised we didn't have that legislation in place, so definitely learned something new. And it actually reflects why we can't just do this alone. We do need to think about the regulatory authorities and our interaction with those systems. Moving on then to Ryan, quite a few questions about lifestyle and how you incorporate that into biomarker work or personalised work and prevention as well.
Yeah, sure. So obviously in the hypertension guidelines, lifestyle is kind of step one, but we see usually even with lifestyle, most patients still need treatment. So it's something we can incorporate. I think the big lifestyle intervention we see working well, particularly in Black African patients who have this salt-sensitive hypertension phenotype, is salt reduction. The problem with that is trying to get the ethical approval, first of all, to try and do a salt reduction study. But we would, so because I'm a pharmacist in the clinic, the idea is to, obviously, I'll have the time to implement the adherence side of stuff and lifestyle intervention alongside treatment. We can't, with the studies that I proposed during the fellowship, we can't implement lifestyle because the aim has kind of already been done, but it is a really important point. I think around salt reduction, I think it really comes down to public health messages and education. And I think the big problem with it is the fact that we're not very good at screening for hypertension, is the first point. But I think community pharmacy have a really big role to play in this sort of lifestyle intervention, because they're now doing the hypertension screening program. So I think first protocol would be that, and obviously trying to get more pharmacists into pharmacist-led clinics, because obviously in a 30-minute consultation with a consultant at a specialist centre, we don't have the time to implement lifestyle interventions and adherence as well as optimising treatment. But yeah, definitely really important point for hypertension control.
Great, thank you very much. Matthew, I'm just trying to synthesise some of the things around autism and what you've presented. This is probably too big a question for a very brief answer, but maybe you can have a go. So there's lots of stigma around autism. Could you share some of the misconceptions that exist and factors about autism that the general public may not be aware of? That's a big one, but so take your favourite.
Wow, yeah, okay. I mean, I guess one of the biggest stigmas is the suggestion that is the idea that a lot of autistic people are very homogeneous, and particularly in terms of social ability, social motivation, potentially intellectual ability, what people are or not able to do. And we have I work a lot with adolescents with mental health problems, and actually one of the biggest drivers of their mental health difficulties can be around that they actually really want to socialise, they really want to form strong friendship groups, but they don't always have the ability to do so. And so some of the work around the sensory sensitivities as well is we have lots of young people who, for example, would love to go to a shopping centre with their friends, because that's a normal thing to do as an adolescent, potentially. It's been a while, so I'm not entirely sure. I remember that being. But that environment might be aversive. So they might try to go, that might lead to high levels of anxiety, that might kind of be seen as a social failure. And so there are lots of things that are actually assuming that people don't want to do these things means that we don't always try to facilitate those things to happen. So that's the one that most commonly comes up in my practice, but I think there are many, many others.
And I guess
also.
It's this assumption that what is innately autism is often wrong.
Yeah.
And the reason people may have social difficulties may be for quite different
exactly.
explanations like anxiety, sensory difficulties.
Yeah, and not motivation or want to be social.
Yeah.
Gráinne, could I come in on that? I mean, I think it's interesting hearing about that. I think it's clear that across a range of other conditions, stigma is a major issue. I mean, the area I work in, liver disease, is very stigmatized. So there may be something we can do more broadly that brings out the learnings from how we deal with stigma in certain conditions, across the full range.
And I think actually that's where lived experience experts come to the fore, because it's all very well us deciding there are these different explanations for why people maybe aren't engaging with some of the health systems that we're proposing, and we certainly need to do better at that. And I think hopefully we're moving that direction. This is a question. I think maybe Phil, but anyone feel free. Given the increased complexity associated with personalising each pathway, how are we monitoring the impact on primary care of these changes, or are we envisaging secondary care as the location for treatment selection? So I guess that's in terms of new interventions.
I think the reality, as you indicate, is that there's a growing, multimorbidity is clearly going to be the dominant driver, and if you think about obesity as being one of those. So I think we probably need to think, and this is our opportunity, as to how we can reshape care pathways, because anecdotally you'll find that individuals attend several different disciplines. So I think, and I think the opportunity exists now as to how we share that with primary care, because I think the direction of travel has been asking primary care to do more and more, and yet it's very clear that that capacity isn't there. There are real challenges there, and I think many in the room will be specialists, and they'll realise that actually their patients have many other conditions. So I think my view is that we should try and more broadly move to a sort of multimorbidity system, which may have shared ownership between the general practitioner and a general physician, but then weaving in the specialists as needed. But it'd be interesting to hear what colleagues think as well. I mean, pharmacy would be
We've got pharmacy.
Yeah, so I was going to jump in about hypertension. So we would say that hypertension is actually a primary care condition. The problem is there's very few pharmacist-led clinics in primary care and in secondary care as well. So we're seeing a lot of referrals now to our specialist centres in secondary care. So I think in terms of hypertension and pharmacy-led clinics, I think the research will start in secondary care. We'll get the data, but the message can be led back to primary care. And inevitably, I would say in the next 5 to 10 years, I would say most of hypertension will be run by pharmacists and in primary care. And we only really need secondary care for those difficult to treat, so resistant hypertension, but true resistant hypertension. So whenever the patients aren't responding to three different drugs. But I think in order to recruit the patients and the kind of difficult to control patients that we need for the research studies to really delve into the mechanisms behind that difficult hypertension, we need to recruit from secondary care primarily. But the message definitely will be extended to primary care for hypertension anyway, but I'm not sure about your areas.
I was just thinking about metabolic associated liver disease, which I think is much more often now being managed in primary care, and our thresholds for keeping those patients in clinic recurrently are going higher and higher. And so also I guess some of that will be about providing resources for GPs to be able to kind of manage that and support them. Because we're going to be relying on them so much more.
Absolutely. It kind of links, or I'm going to try and make a link between there's a poll that tells me how many people are ticking against a question. And unfortunately, this one says for Gráinne, but I'm going to make you all share the answer. We've been talking about personalised health for years. True. What, in your mind, is the single most important thing to make this a reality at scale? And I was thinking about this as I was listening to your answers, and actually, for me, the single most important thing is probably a mindset change to think whole person and interdisciplinary. So in the sense of co-occurring conditions and thinking about brain and body together so that we aren't acting siloed. And that's a sort of cultural shift, I think, that should happen right across the piece from the research we do into understanding the genetic and environmental determinants of disorders, understanding that what is predisposing to mental health problems is often the similar sort of etiological factors involved in diabetes and immune conditions. And therefore, we should be training up our health force to have that appreciation of that intersectionality. We should therefore also be thinking about the individual in the clinic. Even though we have a short time with people, we do have a responsibility to think a little bit more broadly than they've come to see me because of this one thing. And that makes life terribly difficult for general practitioners who are then left with the job of pulling all together these one things that all these specialisms are telling them they've got to get on with. And finally, there's a question about data. Data is really where we start to learn, I think, how to make this intersectionality work. And if we could harness and make this revolution that Lord Darcy suggests can happen from our really broad and deep data sets in the NHS, then we could potentially have something at scale. So that's my answer. And I don't know if anyone else wants to dive in with their single kind of solution.
Well, it's not a solution, I don't think, but it's just a comment. I think something around work on prediction, detection and treatment happening in parallel along the same lines, because I think there's an issue of being able to identify groups but then not have anything to do with that group once you've identified them, and that makes the personalisation less helpful, or the treatment lags a long way behind the detection. I think if those things move in parallel, then the speed at translation in theory would be faster.
And I guess also thinking about secondary prevention, preventing people becoming one condition, a second, a third, a fourth, and so on, which is kind of what happens at the moment. Anybody else want to think about those things?
I was going to say, one of the things that I rely on heavily in my clinical practice, I think, is good tools to stage disease and tools to predict prognosis, so prognostic tools. I think those are two things that really help to personalise whether you keep an extra eye on somebody or maybe you feel like they can go back to clinic, they can kind of be looked after by their GP, or we don't need to see them as often. And I think those are two really important things that need a lot of development.
Yeah, so it's Phil and then maybe Ryan.
I mean, it's a really interesting question, and I think there's probably two elements. I think it's the practitioner having an awareness of the different dimensions. It might be a staging dimension, in other words, more severe you use X versus Y, or it might be ethnicity, or it might be comorbidities. And I think at some level, you can imagine a multidisciplinary system being a way to enable that. The question is how you scale that out, and there are clearly challenges. And I think this is where data might be helpful. So one of my colleagues in Birmingham created an app whereby if a patient who'd had a cardiovascular complication, it would put in all their details and it would flag up all the different guidelines and all the recommendations. And that could include dimensions such as severity, ethnicity. So I think we need to harness electronic healthcare data to make it easier. But I suspect it will be a kind of combination of multidisciplinary and that type of approach.
Any thoughts, Ryan?
I would agree with everything. I think for me particularly, I think it's just more that we treat the patient as an individual, get to know them if you have the time in the clinic, get to know their story, but it's about involving them. I think that's where PPI groups are really important, but it's sort of they're at the centre of their care and they're the key decision maker in it, and you work with them rather than like the team works separately to them. They should be part of that multidisciplinary team. But again, it's a hard one. I think I would maybe really start back at the start and say this is something KHP is really good at. To get personalised medicine to scale, it's schemes like this that we were funded through is just really important, and supporting clinical academics from pre-doctoral right through to the end. I like to think that we will be future clinical academic leaders someday, hopefully. But I think it's something that these partnerships are really good, is funding personalised medicine research right from the start, from the pre-doc right through the doctoral and then to the post-doc. But it's about giving as well. It's not easy when you work in the NHS, but giving the clinical academics protected time to really do this is really important as well.
Thank you. I completely agree. And with an eye to time, in not many seconds, you all work with quite complex concepts and research. How do you manage to explain this in lay terms to patients, friends, and family? Anybody want to have a shot?
I guess I'm quite lucky in the sense that whenever the trial I talked about, the AIM-HI trial, there was a PPI group set up as part of that. So they were recruited from the hypertension outpatient service at St Thomas's, but they're still there for our other cardiovascular studies and the same PPI group that will be used for my fellowship. So I'm lucky that I kind of have that infrastructure there to go to with my sort of consent forms and patient information sheets and get their opinion on it. So I'm kind of fortunate in that sense.
I might put Yevedzo on the spot just because, you know, you have the most complex area to...
Well, I mean, I love talking about gut microbiome and what it does to chronic liver disease. I talk about it to my dad, my family a lot, and they are not medical at all. So I often get a lot of feedback. You know, I practice my presentation with my dad as well, and he's like, what's this, what's that? So talking about it constantly to people who aren't medical. Yeah, I find that very helpful. And patients in clinic as well. And when I write my clinic letters, I write them to the patient, which always forces me to put things in lay terms. So that's one way. And then, I mean, PPI and focus groups are so important in research, and that's something that I am kind of learning about and trying to incorporate as much as possible with this project, because it's going to be really important.
Fantastic. And I think that's a really nice way to end. And it's break time, so I understand there's coffee, probably snacks, so please go and enjoy.